Continuing mobile education for emergency medical services providers. This is Procedures in Geriatric EMS, Episode 1, Spinal Immobilization. At the end of this episode, you should know the indications for spinal immobilization in the older adult and be aware of potential challenges in applying spinal immobilization in older adults.
When we look at suspected spinal injuries, we have to have that lower threshold when we're looking at the older person. The mechanism of injury that for a younger adult is not going to cause an injury, for an older adult will. So we need to look at that fall from a standing height in a younger adult. It's not a big deal. We just get up, we shake it off, we won't even call 911. But for an older adult, it can lead to a dramatic injury because the bone mass isn't there. So we have to have that lower threshold when we're assessing the patient. When we look at our regional protocols, we state that anyone greater than the age of 65, we can't use the suspected spinal injury protocol to decide not to backboard them. If we think they have that mechanism of injury, if we think they might have injured their neck or their back, they should be spinally immobilized. With older adults, the thing to remember is their bone mass is less on average, and their skin is more susceptible to injury than the younger adult. So when a person sustains a suspected spinal injury and we go to immobilize them, we want to be very careful and make sure that we pad them as we put them on whatever the appropriate mobilization device is. We also need to have a lower threshold for suspecting a spinal injury. A trip and a fall that for a younger adult is just normal trauma, for an older adult can lead to a significant spinal cord injury because the bones are not as strong, the muscle is not as strong, the ligaments aren't as strong, so they're going to be more likely to injure themselves. And the other challenge is that they're less likely to feel pain. So a younger adult will feel the pain associated with it and sense that they're injured, but an older adult will not have as much success in receiving that pain message from the injury, so they might not realize that they're having the injury. So the same injury in an older adult will have less pain. The injury might be worse because the bone structure just isn't there to support the injury. And then once we put them on the backboard or the scoop stretcher or the other immobilization device, if we leave them there for long, they're going to get pressure sores very early on. And that's something that we need to make sure that we assess that spinal cord injury, the potential for it early, so we can get them off the immobilization device if they don't need to be on it.
Older adults suffer spinal injuries from less severe mechanisms compared to younger patients. An older adult may not feel the pain from acute injuries, and EMS providers should have a lower threshold for spinal immobilization in older adults compared to younger patients. How can EMS providers limit the discomfort of backboarding while at the same time ensuring the spine is protected?
And the important part of that is padding. We tend to forget to do it. And with a healthy younger adult, they're not as likely to complain. And an older adult, they may be more sensitive to that. So areas that we should consider padding is putting a towel or one of the bundled linen packages underneath their lumbar spine, and again underneath their knees, will help them feel a little bit more comfortable in it. Interestingly, there's some studies that have been shown that the best thing to put on a backboard is bubble wrap. I can't think of an EMS agency in our area that does it, but it's actually inexpensive. You can just tape it to your backboard and then you put your patient on it. They did a study at UCLA that showed that reduced the pain of being on the backboard quite dramatically, and it's relatively cheap. Just something to think about. Fortunately, our transport times are pretty short, and people are taken off the stretchers pretty quickly in the emergency department. Again, when we're talking about the older adult, the chance that their skin is going to be more susceptible to injury, they're going to be more susceptible to pressure sores, is very, very concerning, something we need to be aware of as we're taking care of the patient. EMS often gets kind of cavalier about it because we're hopefully only with the patient for 15, 20 minutes, maybe an hour at tops, so we don't think that that's an injury that can happen. Hospitals are used to being concerned about that, but in EMS we tend to forget about it. An older patient is going to be more susceptible to it, particularly if they're on steroids for long term. Their skin is very brittle and they're going to be susceptible to getting this. And getting a pressure sore might sound like not a very big deal, but that then leads to infection and a deterioration of their health.
There are a few special conditions that make backboarding geriatric patients different than backboarding other patients, whether it be child or adult. And one of those are kyphosis. Lots of times you may see elderly patients who walk around kind of look like what we know as a hunchback, but they suffer from kyphosis, which is a curvature of the spine, of the thoracic spine, which just causes them to kind of hunch over. Their shoulders might be hunched over. They might appear shorter than they actually are, and different things of that varying nature. It can be caused by bad posture over a lifetime or a certain amount of time, or it could even be caused by some type of muscular or structural abnormality or deformity that they have from some other condition. The one thing to keep in mind when you're backboarding patients that might suffer from kyphosis is that you want to give them additional support and padding that's necessary for them to be comfortable and to not kind of maybe irritate or disrupt any damage or injury that's already there. So what the person who's, let's say they're person who's kyphotic, they suffer from kyphosis and you're trying to put them flat on the backboard. Because of the natural arc in their back, it's kind of hard to lay them flat. So you might want to take some pillows or extra blankets, emergency blankets, and definitely support those other areas of their body, like the cervical spine, behind the shoulders, and behind the head, so that you don't have additional strain going to those parts of the body. And sometimes you could even find it necessary to pad under the legs or some other lower region of the body, depending on their level of comfort. And I'm sure they'll tell you, more likely than not, they'll tell you if they're uncomfortable in any way. So you won't have to play guessing games, and they'll be very helpful in that sort.
Another concern with age is you'll have an older patient may become dyspneic when they're supine. So if they're lying on their back, they'll have trouble breathing. We want to prevent that. So how can we appropriately make sure they're treated for their suspected spinal cord injury, yet still be able to breathe? And this is a challenge. This is an age-old issue of what can we do, what's the best for that patient. If we know we put them down, they're going to have trouble breathing, can we elevate the backboard a little bit? Will that help? Maybe having them immobilize and tilt them to the side a little bit. Will that help? Or worst comes to worst, is there some secondary way of immobilizing their spine? Maybe we have them in a KED and sitting upright a little bit on the stretcher, because if we know when they lie flat they're going to have trouble breathing, so we have to do something to treat the suspected spinal injury as best we can, yet still allow them to breathe. It's not an ideal solution, but it's certainly better than not treating the backboard or not treating the suspected spinal injury to allow them to breathe, or treating the suspected spinal injury and then making it very difficult for the patient to breathe.
Be sure to pad bony prominences to prevent undue pressure that may cause skin breakdown. Medications, such as steroids, may make skin breakdown worse. Use blankets or other padding in kyphotic patients. And remember, older adults may experience respiratory difficulties when supine. After viewing this episode, you should know the indications for spinal immobilization in the older adult, and be aware of the potential challenges in applying spinal immobilization in older adults.